RMT and 4-up defect, we reconstruct with the palatal island flap. So these local flaps can have a great role, but we need to understand all these flaps, anatomical considerations, and also what are the key areas where we can have complications, and we should try to avoid this. This is a patient who had an entire buccal mucosa defect, again a high risk patient, not fit for free flap surgery, reconstructed palatal island flap. So I'll just finish. I'll try to go quite fast because this is a submental flap. Submental flap is usually used for in N0 neck patients, and the venous problems can be quite challenging with this flap because sometimes the submental vein is not the main draining vein. It could be the external jugular vein or anterior jugular vein along with the submental as a main venous drainage pattern. So whenever we island the flap, the lymphatic tissue should be avoided along with the pedicle, and whenever feasible, we should try to take additional venous drainage like facial external jugular vein or anterior jugular vein, so that we get a good blood supply. With a good islanded submental flap, the reach can be quite good up to the buccal mucosa, or we can use it like a advancement flap, the contralateral carotid defects or ipsilateral carotid defects also, so that we can avoid a free flap in significant number of patients. So this is used for contralateral side neck dissection defect. Usually we end up problems with venous congestion early period, and in male patients who do not require radiation, the hair growth in the oral cavity can be a significant concern. So nasolabial flap is one of the other local regional flap. It is a very common flap where we tend to use it for a very large defect, and this can lead to trismus, and if you are using it for as a bilateral flap, it can lead to macrostomia. So preferably we use it for verrucous carcinomas in females, or after a small after a coronodectomy on the contralateral side to improve the mouth opening. So these are flap specific complications. It could be because there could be regional specific complications like for lip reconstruction. If you do not address the lip defects adequately compared to, especially when there is a combined buccal mucosa defect, I think there is a session on this in the afternoon, so I'm not going into depth. So we can get a complication like trismus or lip competence. The overall reconstruction may seem alright, but significant lip incompetence like this is a major complication because this will not help the patient to mingle in the society, and also the overall cosmetic result also will be poor. So for pure localized lip defect, we can use flaps like Abbé flap, or this is midline upper lip defect, we are using Abbé flap, and or else you can, for lateral defects or bigger defect, we can use Gillies fan flap, and for sometimes for combined defect, it may be good to use free flap along with local flap. This was a lady who came with lip resection along with mandibulectomy. We did a fibula flap. We looked at the option of providing fibula skin only for the lip reconstruction, but there was a significant lip droop. Since she had a quite wide oral cavity, we planned a Eastlander flap, and this is the result at 3.5 months. So it could be because we can use combination of flaps also to get good results. So to conclude, I think local regional flaps have a definitive role. So whenever you are using any local regional flap, we should know the specific advantages and disadvantages of each of the flap. And one flap for all the defects, I think, is not a good solution. You need to understand various flaps with respect to their limitations and advantages. Free flaps are now a good standard. We can combine local regional flaps along with free flaps. The aim should be to get a good functional aesthetic results. In our Indian scenario, defects tends to be very complex with exorbitant demands. So whenever we are using any flap, whether it's a local flaps or free flaps, one of the first things we need to do is we need to assess the defects correctly, and we should plan a flap which can defect all our concerns, whether it's a local flap or a free flap. And there was a saying, do not be a slave to incision. I think we should not be a slave to a single flap also. And each flap has a definitive indication and territory. Understand that and try to apply to each defect, and analyze the aims of any reconstruction and try to achieve the best possible form and function. Then we can decide whether we should use a pedicled flap, free flap, or a combination flap. For many of our defects, I think we need to learn our techniques, innovate and improvise, or it may have to be done in a single or multiple stages, so that we give the best possible function and aesthetics. I know there are always limitations. It could be because from the patient side, or it could be because from the surgeon side, or it could be because of multiple circumstances. But I think we can use our best possible knowledge to give best for each patient in every situation. Thank you so much.
Thank you, Prashant sir, for taking us through all these local and regional flaps. Any questions from the audience?
So it was a very good, concise talk. You raised a very good point, sir. While harvesting PMMC, if we go in the plane between sternal and clavicular head, we might end up injuring the pedicle. Sir, if it happens inadvertently, then what to do next? Do we give, since we are all trained in microvascular surgery, can we give an attempt to try doing micro?
You can definitely do that.
And if you have any experience, does the flap survive after doing that?
I think it depends on, most of the time whenever we are doing PMMC, we are using cautery, and probably cautery settings are quite high. And the injury, you have to detect the injury. If the flap is completely in your hand, then probably it's a difficult situation for you to analyze where exactly was the defect. But if the injury has been detected at the moment where you have hit the pedicle, I think you can take a decision. I think whether you can try to decide to convert it to a free flap. There is a lot of collateral damage which happens when you are using high level of cautery. I think it is better you dissect about 1 centimeter or 1.5 centimeter of the pedicle, so that there is no collateral injury into the pedicle. Because what happens is this can lead to late complications. You may have early survival, late failures can happen. I think if you go with that, flap should be salvageable, but I have not done it.
That's good to know. And the other thing is, sir, whenever you are doing PMMC for inner lining and outer cover, you always deepithelize, or you prefer to divide the paddle also? Like you said that if we keep the entire skin paddle over the muscle, we can might as well divide it also.
Yeah,
so what is your
I think
preference?
that's a very important question. So it lot depends on what is the dimension of the neck and what is the dimension of the chest. I think that's what determines how your bipaddle PMMC is going to be done. If you have a very short neck and a very long chest, I think you can do the division. Your flap will be pretty long, you can use it very nicely. But if you are in a opposite situation where the neck is quite long and your chest is short, then I think if you want to do division of significant deepithelialization of the flap, the reach related issues may be there. Because I have seen, this is the pattern that I have used, the transverse pattern. With the transverse pattern, the reach to the oral cavity for both inside paddle and outside paddle is easier. But I have seen surgeons who are using vertical paddle also. If you're using a vertical paddle and if your chest is short and neck is long, then you usually tend to fall short and you end up with complications.
And there's one more picture you had shown about the DP flap. It was crossing the third aneurysm. You had delayed it before, sir?
Yeah, it was a delayed flap. This was actually done when I was in my fellowship at PMH. I think I should
Oh, wow, you still have this picture.
Yeah, because it was a PMMC flap. I remember, I think they did multiple flaps in it. Before it was done, I think even PMMC was also done, I guess. So the only option that was left was DP was remaining. So we had to do a DP. DP was got for out the skin, and inside paddle was also skin grafted. There was no inside paddle, so it was skin grafted, and I think we did a delay later. But I think microvascular surgery, I think we can avoid many of these problems.
And one important point I would like to highlight in PMMCs in females is that you have to do donor site examination. Sometimes it might happen that you will find an incidental lump in the breast. So I think that would be a disaster, and always the breast should be palpated before you're planning a PMMC in a female. And in nasolabial, sir, I agree with you, it causes trismus. Especially many people say that you can do an islanded nasolabial for tongue reconstructions, but yes, it later leads to trismus because they go for
many of the time the key problem is you are using a small flap for a very big defect, or probably using a very big flap like a PMMC for a very small mandibular reconstruction, for small marginal mandibulectomy. I think these are the very common problems which lead us into trouble.
So one question, could we substitute a ram flap for a PMMC in women?
Ram flap is rectus abdominis. As a pedicle flap? Because the reach wise, I think the ram would not go quite higher. Maybe I have not used it. I think as a free flap, it was one of the very popular flap in the past. Considering the rectus, if you take the entire rectus muscle out, there is lumbar donor set mobility. So because of that, the ram flap has given way to the ELT flap now. But it's a very good flap. It's a very robust flap.
Sir, you have shown us that Submental flap is being used for laryngeal reconstruction patch. How about the donor area? Because there is a small paddle tunnel. When you made a tunnel, it's a very small. If you can share that experience.
Yeah, I think supraclavicular flap is a very robust egg-shaped flap. I think the blood supply runs quite axially, So in case you have a small segment with the flap is not reaching your defect, the defect is quite higher in the pharynx. So we can deepitalize a small portion of segment so that deepitalized segment will come at the level of the normal esophagus.
But after the neck dissection, usually we end up with doing level 2 to 4 when we do for larynx. So how about the vascular?
Many of the times, these patients will have received radiation, and some of the patients end up with a pure laryngectomy. They could be because of dysfunctional larynx, or there may not be any residual disease, or a suprastructural laryngectomy. So in those kind of defects, I think you can use all these patients that we have used, they were not used at a per primum setting. They were all later when they came up with some complication.
Yes, sir.
Thank you, sir. Thank you very much.
Thank you.
Sir, I would like to call you to felicitate sir for the session.
Sir.